round of applause as she comes to the stage.
Good afternoon, everyone. My name is Dr. Rose, and I will stand on the existing protocol. So I know we've been hearing different lectures, and then I hope we've learned a lot. So we're going to just go through some case scenarios, okay? Okay, so scenario one. This is baby AG, a preterm male neonate who was referred to our facility at 10 hours of life. He was delivered at 27 weeks plus 1 day via cesarean section. Abuja score was 5 and 6 in 1 and 5 minutes respectively. The birth weight was 0.7 kg. At presentation, he was in respiratory distress, technically. SpO2 was 78% on intranasal oxygen. The baby was hypothermic, foul smelling, there was dry amniotic fluid on the body, and there was a history from the referring center of queried maternal chorial pneumonitis with purulent eye discharge. When he was admitted to NICU, we commenced incubator nursing. The UVC was passed. There was a bloodletting chart created. He was nebulized with surfactant. This is because the baby was small and we were having difficulty when we were trying to intubate to give the surfactant. And it was commenced on CPAP. SpO2 was rose to 98%. The investigations done are listed there: full blood count and malaria parasite, EUCRO, we did serum bilirubin, calcium, serum calcium at 24 hours of life. And then from the full blood count, the child had leukocytosis, neutrophilia, and monocytosis. It was commenced on antibiotics, anti-malaria, caffeine citrate, intravenous fluids, and buccal colostrum. He was managed as early onset neonatal sepsis and congenital malaria in an extreme low birth weight child. Parents of the child were extensively counseled about the clinical state, diagnosis, prognosis, as well as possible complications and then management challenges. In the first week of the admission, there were episodes of apnea, intermittent desaturation. He was commenced on saline nebulization with gentle suctioning, PRN. We noticed that there was bleeding from previous puncture sites. There was prolonged bleeding time, and then this child was commenced on vitamin K1. He had episodes of hypoglycemia that were corrected, as well as hypokalemia. They were both corrected. And then he was placed on prophylactic phototherapy. Trophic feeds were commenced in that first week of admission. He was also commenced on parenteral nutrition and the third day of life. NG was passed. At some point, because of the hypoglycemia, the glucose concentration of the fluid was increased to 12.5%. Repeat full blood count was in downward trend, and antibiotics were reviewed first week of admission. Weight at the end of this first week was 0.72 kg. By the second week of life, or on admission, sorry, the apneic episodes continued, and the child had to have a repeat surfactant given. Feeds were gradually increased, and then, we had to withhold for temporarily, because we noticed that there were brownish effluents, and then it was afterwards when we noticed that had stopped, we gradually increased the fluids, the feeds. By the 8th day of life, we noticed that the child was anemic, for which he was transfused. The UVC was removed by the end of the second week, actually, not the third week. That's like day 14. Then catheter tip was sent for MCS. Antibiotics and phototherapy were discontinued at this point. He was euglycemic by the 15th day of life. Glucose concentration was reduced from 12.5 to 7.5%. Feeds were gradually increased. There was repeat transfusion. The CPAP was changed to intranasal oxygen. And then child was started on thrice weekly erythropoietin, and hematinics were commenced. Well, in that third week of life, we were having some challenges with getting patency of IV access. He was at the 4th week on admission. He was commenced on prokinetic. Soya oil was added to each meal. Child had occasional vomiting and regurgitation. Was weaned off intranasal oxygen, and the repeat food blood count was within normal range. Breast milk fortifiers were commenced at that week. Baby remained stable, was managed as a feeder graph from the 5th week to the 9th week, and continued on subcutaneous erythropoietin. Prokinetics were discontinued by the 9th week. And by the 65th day of life, baby was discharged home to continue feeding with express breast milk and breast milk fortifiers. And continued with iron supplementation, folic acid, and calcium max. He came for follow-up in 2 days' time, and we have been following up since then. Baby is doing very well. The discharge weight at the time of when the child went home was 1.94 kg. So scenario 2, we have baby CH, a preterm neonate who was the only surviving twin, conceived via IVF, delivered at 32 weeks on account of preeclampsia. Abuja score were 8 and at 1 minute and 9 at 5 minutes. Birth weight was 1.6 kg. He was transferred from a referring facility at 56 hours of life. At presentation, he was in respiratory distress. There was hypothermic, there was hypoglycemia that were corrected. The baby was jittery, mildly etheric. We did some variety of tests which are shown there. MP, which was scanty, serum bilirubin, full blood count, and blood group. He was admitted to the NICU. UV was cited, and then incubator nursing started. He was commenced on IV histamine, IV fluid, caffeine citrates, IV anti-malaria, prophylactic phototherapy for jaundice. He was noticed to have hypocalcemia, and IV calcium gluconate was commenced. The other investigations that were done were blood culture and catheter tip MCS. In the first week on admission, the child's feed was gradually increased. By day 4, he was noticed to have a low-grade temperature. So we did a repeat food blood count which showed leukocytosis. IV antibiotics were commenced on that account. By day 5, he was commenced on intranasal oxygen from the CPAP. But we noticed that the child continued to have jitteriness. So serum calcium was corrected. Okay, but the weight increased from 1.4 kg. Second week on admission, child developed a high-grade temperature. We did the BAT tech at this time, the result was ready, and then it yielded Klebsiella, and the catheter tip revealed multi-resistant staph aureus, and then antibiotics escalation was done. The child was anemic and then had to be transfused again. Abdominal distension was monitored because we noticed that the child was vomiting and the feeds had to be withheld temporarily. Edema was noticed too on this second week on admission, and IV furosemide was given. Child was noticed to be having seizures at this time, even though he had a normal electrolyte reading. So anticonvulsants were commenced. KMC was encouraged, parents were excessively counseled, barrier nursing was reinforced, and at this point, weight was 1.46 to 1.6 kg. By the 3rd week on admission, anticonvulsants and calcium and caffeine citrate were completed. Repeat MP showed scanty, so the child was added on oral anti-malaria. Antibiotics were discontinued. The NG tube was removed. Baby was tolerating oral feeds. He was moved from the NICU incubator to a cot, and then from there, he was gradually moved to the ward after he was stable enough. Weight at this point was 1.7 kg. 4th week on admission, child was continuing to do better and tolerate feeds, and they were increasing gradually. He was maintaining saturation and temperature, and then discharged on that 4th week. And discharge weight was 1.96 kg. He was discharged on serum astifa iron, multivitamin, calcimax, erythromycin, and then came for follow-up in 2 days and was making steady gain of weight. We have been seeing subsequently, and the child is for a repeat echo at 6 months of life. So having said this, these are the two case scenarios we have to present. We're going to move from babies to a bigger picture. So this is just like an add-on for our advanced pediatric life support. Sorry, can someone help me play there's a video there, a mini video. Can we just play it? Down to the right of the slide. Well, okay, so all the video is going to deplete is we're going to move from babies to older children. So this is just an add-on. This is a pediatric symposium. And then we're talking about neonates, but we're just going to give, do an add-on for an algorithm for the advanced pediatric life support. So neonates sees differently. Like I said in one of the previous slides, one of the babies had seizures. But seizures are one of the managed the same way. We follow the principles of safe and structured escalation when we're managing them. Seizures are one of those things that bring patients to our emergency rooms, even in the pediatric, in older children. So we want to look at one of the algorithm of managing status epilepticus. Now, this is the algorithm. So if a child is rushed to the emergency room, if a child is rushed to the emergency room having status epilepticus, what does the guideline say we should do? That's what this is about. First, we will start with our normal ABC of resuscitation. The child is brought in, we want to secure the airway. But you must keep in mind that this child is probably coming from somewhere. So they may have administered something to the child, like diazepam. So you take note of that. If the child comes in, the airway is secure. You want to find out if the child has had any previous diazepam administered, and take note of how many doses. Now, when the child presents, if you can set an IV access, you will start by giving the child IV lorazepam or IV midazolam. If you cannot get a vascular access, you will give midazolam, but you can give it buccal or intranasal. If that is not available, you can then give diazepam rectal. Now you wait for 5 minutes from onset of the conversion to do this. You monitor this child closely. If after this 5 minutes, the child is still convulsing, you will check again, the same thing, ABC, resuscitation. Then you administer, remember I said that you take note of whether the child took anything before coming to the hospital. If you had one previous one, this would be like the second dose. The first one will be second dose for that child. But if the child has not had any diazepam, any benzodiazepine, you will give a second dose at this point. If there's vascular access, you give another dose of IV lorazepam or IV midazolam. If there's no vascular access, you give it buccal or intranasal. If you don't have that, then you cannot give rectal diazepam. If after 5 minutes again, this child is still convulsing, then the same pattern, you check to make sure that everything is fine. But what I forgot to add is, when you examine the child, when the child presents, of course, when you are doing your history taking, you want to rule out every cause of convulsion. So if this child, you want to maybe check the level, you want to take your urgent EUCRO, just to make sure anything that is ongoing is corrected. Now back to the step 2. If this child is still convulsing, you've checked the child ABC of resuscitation, and now the child is still convulsing. The child is no longer convulsing. You send the child to be monitored. If the child is still convulsing, after that second dose, you give levetiracetam to the child. Now, after 10 minutes, you monitor that child again. And the convulsion is still ongoing. At this point, if the child is not convulsing at this point, you send for monitoring. If the child is still convulsing, at this point, you now start the child on phenytoin. If the child has already had phenytoin, sorry, what I didn't say was that in the previous place, if you don't have this levetiracetam, you can also give phenytoin if you have that. So yes, so that's why they're asking if you have given it already. You're already on phenytoin. If the answer is no, you commence phenytoin here. If the answer is yes, he has already had a dose of phenytoin, you commence on phenobab. Then you monitor the child closely again. If the child still continues to convulse at this point, this is the point where you now send a message, you prepare your, if you have a pediatric critical care unit in your hospital or facility, you send a message to them that there's a child who is convulsing that will be referred to them. But if you don't, maybe find a facility that you will refer the child to. So at this point, you are preparing to actually commence ketamine for the child. So while you're monitoring, you're also making preparation for this. Say the convulsion doesn't abate. At this point, you want to refer the child to a facility where the child can be monitored and properly taken care of. And then you commence the child on ketamine. If you don't have ketamine, you could also do tiopetan or propofol. Thank you.